Hi everyone, my name is Lily Brucker. I'm presenting on conversion disorder, which has the DSM codes of F44.4 through F44.7. So a general overview of conversion disorder is that it's also known as functional neurological symptom disorder, and it's a mental condition that usually occurs after a stressful or traumatic event, and individuals experience physical symptoms such as blindness, paralysis, or any other type of neurological related symptoms such as swallowing, um, seizures, and all different types of symptoms that I'll talk about more later. And if you guys have ever seen the Netflix show Never Have I Ever, in season one, the main character sees her dad die in front of her and goes paralyzed for a brief amount of time. And she's diagnosed with conversion disorder because that paralysis eventually just goes away once she starts to work through her trauma. So, for the diagnostic criteria, the first criteria is that there's an altered voluntary motor or sensory function. There's an incompatibility between the symptom and recognized neurological or medical conditions. The symptom or deficit is not better explained by another medical or mental disorder. The symptom or deficit causes clinically significant distress or impairment in social, occupational, or other important areas of functioning, or it warrants medical evaluation. And conversion disorders often associated with dissociative symptoms such as depersonalization, derealization, or dissociative amnesia. And these symptoms are usually onset during during one of the conversion disorder attacks. And there can also be a history of multiple similar somatic symptoms, and these symptoms onset could be associated with the stress and trauma. And this trauma could either be physical or psychological in nature. So for the specifiers, the first specifiers are F44.4. The symptoms are weakness or paralysis, swallowing symptoms, speech symptoms such as slurred speech or dysphonia. Dysphonia is when you have an irregular voice, such as a hoarseness to your voice. And then there's also abnormal movement, such as tremor, dystonic movement, myoclonus, which is when you have muscle spasms, or gait disorder, which just means that your gait is kind of irregular. You might be shuffling or falling or just any of those things that make your walk irregular. For F44.5, there's attacks or seizures for the symptoms, and then F44.6, there's anesthesia or sensory loss. There's a special sensory symptom, visual, olfactory, or hearing disturbance. And then for F44.7, it's a mix of symptoms of F44.4 to F44.6. So you can have anything from F44.5, such as attacks and seizures, or F44.4 of weakness or paralysis, and then also F44.6 of sensory loss. And then you also have to specify if it's an acute episode, which means that the symptoms are present for less than 6 months, or if it's a persistent episode where the symptoms have been occurring for 6 months or more. And then you also have to specify if there's a psychological stressor and specify the stressor, or if there's not a psychological stressor. And as for the course and prevalence, it's common for conversion disorders to last for a brief amount of time, and the exact prevalence of conversion disorder is unknown. This is partly because the diagnosis usually requires assessment in secondary care, and not everyone always goes to secondary care. And it has been found that in secondary care, there's approximately 5% of referrals to neurology clinics that actually have conversion disorder. And it's said to be that about 2 to 5 out of 100,000 individuals per year experience persistent conversion disorder symptoms. And for the development and course, onset has been reported throughout the life course. The onset of non-epileptic attacks, which means people who aren't having seizures, peaks when someone's in their 30s. And the onset of motor symptoms peaks when someone's in their 40s. And the symptoms can be transient or persistent. Transient just means that they last for a brief amount of time, and persistent means that they're reoccurring. And the prognosis may be better in younger children than it is in adolescents and adults. For cultural considerations, if the symptom changes resemble conversion disorder symptoms, and they're common in certain culturally sanctioned rituals. It's just an important thing to note. And if a particular cultural context fully explains the conversion disorder-like symptoms and a person's not experiencing clinical significant stress, then they should not or will not be diagnosed with conversion disorder. They'll just have the cultural context explain the symptoms, so long as someone is not having a really hard time with the symptoms mentally and physically. And conversion disorder is 2 to 3 times more common in females than it is in males. As for the prognosis, for temperamental, maladaptive personality traits are commonly associated with conversion disorder. Environmental, there's a potential history of child abuse and neglect, and stressful life events are usually present, but not always. And for genetic and physiological, there's a risk factor that involves the presence of a neurological disease that can cause similar symptoms to conversion disorder. And then course modifiers, there's positive prognostic factors such as a short duration of symptoms and acceptance of the diagnosis. And there's negative prognostic factors such as maladaptive personality traits and if a person is a recipient of disability benefits. And for the history of conversion disorder, so the concept of the symptoms of conversion disorder started being paid attention to back in ancient times when Hippocrates, the quote-unquote father of medicine, came up with this concept of hysteria, which is known as when the uterus dries up and wanders the body in search of moisture, and those physical symptoms that happen after the uterus does that are what is known as hysteria. So in the 19th century, neurology became associated with hysteria symptoms. In the DSM-1, conversion disorder was known as conversion reaction. And then in the DSM-2, conversion disorder was grouped with dissociative disorders as hysterical neurosis. So both dissociative disorders and conversion disorders were grouped under the term of hysterical neurosis. And then the DSM-3 got rid of the classification of hysteria and replaced it with conversion and dissociative disorders. And then the DSM-4 decided to separate conversion and dissociative disorders, with conversion disorder still being classified as a somatoform disorder. And somatoform refers to the physical symptoms that cannot be attributed to organic disease and appear to be of psychological origin. And as for the DSM-5, conversion disorder is still known as conversion disorder or functional neurological symptom disorder, and not much has changed between the DSM-4 and the DSM-5 for conversion disorder. So for the past theories of conversion disorder, as I mentioned in the last slide, conversion disorder used to be thought of as hysteria based on Hippocrates' theory that when a uterus dries up and wanders the body for moisture, the body starts experiencing irregular bodily symptoms. And in the 7th century French philosopher René Descartes said that the mind and body are two separate entities that cannot exist in unity, since the body is subjected to mechanical laws and the mind is not. And then in the 19th century, the central nervous system was established to be connected with hysteria symptoms. And Freud also developed a psychodynamic theory that contributed a lot to the development of what conversion disorder is known as today. And the psychodynamic theory states that unconscious conflict and affective motive are transformed into bodily complaints, as in that the body shows symptoms of distress when the mind is in distress. And for the present theories, it's classified as a somatoform disorder, and somatoform disorders are a set of psychological conditions where a person experiences bodily symptoms that cannot be accounted for by a medical or neurological diagnosis. Symptoms can range in severity from mild and infrequent to chronic and severe, and are out of an individual's conscious control. And both the DSM-4 and the DSM-5 theorize that conversion disorder occurs due to recent stressors, conflicts, or traumas. And it's been established that symptoms aren't consciously created or exhibited, that they happen subconsciously due to the body processing the stressors. And learning theory states that the environment shapes and influences behaviors such that if these behaviors become maladaptive, a conversion disorder may ensue. And for example, if someone experiences physical abuse, which is an aversive stimulus, this abuse might trigger attention-demanding behaviors such as pseudo-seizures or aphonia. So what this is saying is if someone is a victim of physical abuse, their mind might not know how to deal with it, so that their body kind of exhibits the symptoms, and they might have the symptoms of like headaches or seizures or weakness in their legs, just all sorts of different things. And socio-cultural theory states that because the expression of intense emotion is not welcome in certain cultures, it's easier to express these emotions physically, and because the physical symptoms are more accepted, the person learns to express their emotional distress through physical symptoms. So in some cultures, like, it's not accepted to cry or be angry or just show any intense emotion. So a lot of people in those cultures learn to express their body and mind, kind of learn to express all of those emotions through like bodily symptoms. And for assessment and differential diagnosis, the most commonly made differential diagnosis is neurological disease, which can coexist with conversion disorder. And then there's somatic symptom disorder, which can be diagnosed in addition to conversion disorder. And most symptoms of somatic symptom disorder can be shown to be clearly incompatible with pathophysiology, which just means pain and fatigue, but that incompatibility is required for a diagnosis in conversion disorder. The excessive thoughts, feelings, and behaviors that characterize somatic symptoms disorder are often absent in conversion disorder. And then there's fictitious disorder and malingering, and that malingering just means that it's the falsification or profound exaggeration of illness, both mental and physical, mental or physical, to gain external benefits such as avoiding work or responsibility, getting drugs, getting attention, getting off of school or work, or just any other reason. And then there's also dissociative disorders, and dissociative symptoms are very common in conversion disorder, and both diagnoses should be made if conversion disorder and dissociative symptoms are present. There's also body dysmorphic disorder, depressive disorders, and panic disorder. So for treatment, one of the main forms of treatment is talk therapy, cognitive behavioral therapy, which helps people identify negative or irrational thought patterns and respond to challenges more effectively. And CBT also can help people build better coping mechanisms. There's also stress management training, hypnosis, physical therapy, medication for any co-occurring disorders such as SSRIs, beta blockers, and analgesics, and benzodiazepines. And treatment is most effective when treating both conversion disorder and any other comorbid disorder. So for the case presentation, Riley is a 35-year-old Caucasian woman living in New York City. She has recently undergone a lot of stress and trauma. She was fired from her job after being assaulted and raped by her boss several times. Prior to these events, Riley has dealt with her childhood, physical and sexual trauma by blocking the events out and retreating inward to the point where the world around her fades away and doesn't seem real. After being fired, Riley begins to experience weakness in her legs that continues to get worse until one day she wakes up and can't feel or move her legs. Riley has never had issues with her body before and considers herself to be in good shape. Most days she relies on walking and biking to get around the city. Riley is in extreme distress at her legs' inability to feel or move and quickly begins to panic about how she's going to spend her days without limbs that she relies on all the time, every single day. So for the symptom presentation, Riley has undergone recent stress and trauma of being fired and raped several times. She has a history of dissociation, a history of childhood trauma, physical and sexual abuse. She is experiencing weakness and eventual paralysis in her legs. She's had no prior issues with her legs. She's very healthy, and she's now experiencing significant distress at not being able to use her legs for a while. And a differential diagnosis would be dissociative disorder, since she has a history of, disappearing into herself and dissociating and not feeling like the world around her is real, or a neurological disease, where it's just something happened and that needs to be checked out by a neurologist. But yeah, that's my presentation. and these are all my references, and thanks everyone for listening.